Good afternoon, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to today's conversation. Before we begin, a word of thanks to Meredith Brown and Alicia Noel and everyone whose work made today possible. These public health conversations are meant as spaces where we can come together to discuss what matters most for health. We join as a community to hear from our distinguished guests who guide us towards a deeper understanding of core issues. Today's guest is Dr. Abdul El-Sayed. He is a physician, epidemiologist, progressive activist, and former health director for the city of Detroit. He is host of America Dissected, a podcast by Crooked Media, which goes beyond the headlines to explore what really matters for our health. And in 2018, he was candidate for governor of Michigan. He's also someone I'm fortunate to be able to call a friend of many years. Abdul will lead us in a discussion of his new book, Medicare for All, A Citizen's Guide, which he wrote with Dr. Micah Johnson. The topic could not be timelier. COVID-19 has shown how inequities in healthcare access represent a crack in the foundations of American health and injustice in need of correcting. I can think of no one better to help advance a vision for progress in this area than Abdul. I look forward to learning from him, as I always do. I will now turn the event over to Professor Melissa Garrido, a professor in our Department of Health Law, Policy and Management, and moderator of today's discussion. Professor Garrido, the screen is yours.
Thank you for that. So I'm pleased today to introduce Dr. Abdul El-Sayed. He's a physician, epidemiologist, educator, author, speaker, and podcast host. His newsletter, The Incision, cuts to the heart of his trends shaping our moment. He's a commentator at CNN, and his 3 books include Healing Politics, Calling for a Politics of Empathy to Cure Our Epidemic of Insecurity, and Medicare for All, A Citizen's Guide with Dr. Micah Johnson. He is the host of America Dissected, a podcast by Crooked Media, which goes beyond the headlines to explore what really matters for our health. He is a senior fellow at the FXB Center for Health and Human Rights at the Harvard T.H. Chan School of Public Health, and a scholar in residence at Wayne State University and American University, teaching at the intersection of public health, public policy, and politics. He is formerly the health director for the city of Detroit and candidate for governor of Michigan in 2018. And we're just grateful to have you here today and looking forward to the discussion. Thank you.
First of all, thank you so much. I really appreciate that warm and thoughtful, meaningful introduction by Professor Garrido. And of course, appreciate always being with a mentor and friend of mine, Dean Sandro Galea. It's a privilege to be with you all at BU. I really wish that we could be doing this in person, but circumstances permitting, grateful to have this venue here on Zoom as well. I wanted to take this opportunity just to step back and situate this book within a couple of conversations I think we ought to be having, and actually are having in the context of this pandemic. The first is, why don't we invest in population health in the ways that our science has demonstrated that we ought to? We have reams and reams of science demonstrating that the real predictors of population health have less to do with what happens in a clinic or a hospital and a lot more to do with what happens in the spaces where people live and learn and work and pray and play. And that those spaces ought to be the places where we situate the interventions that truly do drive population health. And the second question that I want to get at is, why is it in this country that we spend 18% of our entire economy on healthcare? Why is it that despite that 10% of Americans still don't have healthcare? And then the third is, what is the policy and politics to be solving questions 1 and 2? In the first space, right, I actually think that the second question I asked, that why is it that we spend 18% of our entire economy on healthcare despite 10% of non-coverage, is really the answer to the first question, right? We don't invest in population health because in our country, we have taken so much of the investiture that we could be putting into improving in empowering population health into our healthcare system. And that's not a problem of one policy challenge or another. It's a function of a system that is interconnected, that has monetized people's bodies for the profits of large corporations. And then the ways that those corporations have hooked themselves into our public debates and into our politics to serve themselves and to continue to drive more and more of our financial resources and well-being into the healthcare system. And this is a product of a 40-year governing consensus in our country that tells us that the best single way to provide basic public goods rather than through government, an agent of our collective will, through corporations. And those corporations then we allow to create a system that allows them to profit. Meanwhile, excluding those folks who cannot pay and extracting from everyone else. And healthcare is a principle demonstrative of that governing consensus. Healthcare in America is a function of a number of major industries, but two of them that I want to focus in on now. The first is the provision of healthcare through healthcare providers, and the second is the payment for healthcare through health insurers. And oftentimes it's popular to talk about us as consumers of healthcare, right? We think about ourselves as consumers of everything else, so why not just take that analogy and apply it to healthcare as well? But the problem is this, right? Let's say I was a consumer of something like kohlrabi, and I went to the local farmer's market. I decided I want to buy a head of kohlrabi. I think that's how that's measured. And I go to the local artisan farmer and I say, I'd like a head of kohlrabi. I ask him what the price is. I look at the various heads of kohlrabi. I pick one. And then that kohlrabi is the cause for a financial transaction. I pay that particular provider, that artisan, for their kohlrabi. I walk away with the kohlrabi and hopefully I make a delicious meal with it. The problem with that analogy, right, is that I know exactly what I want. I have a choice about whether or not I want to buy it, right? And I can assess whether or not the kohlrabi meets my standards and the price that I want to pay. That's how a market transaction works if you're a consumer. I'm also the one who tendered the money to pay for the service. If you take that analogy and apply it to our healthcare system, right, the fundamental problem is that actually we don't really want to buy healthcare. Nobody really wants to buy healthcare. What people want is health. And after we have failed to improve upon the population's health, to answer question number one, right, that's the moment when people are stuck buying healthcare because they see it as a means to getting back to health. And so healthcare is not a consumer good at all. But even then, if we were to go back to this system, let's say that we're in a position where we need to buy healthcare. If we are privileged enough to have private health insurance, we are in a situation where we and our employer pay every 2 weeks or every month for this product called health insurance, the operative word being sure in insurance. And we expect that insurance to be there for us if and when we get sick. If we do get sick, we're now in a position where we go to a provider of healthcare. We're not really given a choice about price. We aren't really able to shop around, particularly if you're talking about acute care, which is the majority of the cost of healthcare in our system. And then we get our healthcare, but we don't actually pay for our healthcare. Instead, there's a bill that's sent to our insurer, right, who's supposed to be there. Now, the insurer, we expect to be there for us, but they figured out how to pass the cost of our care back onto us in the form of these things called deductibles and co-pays and co-insurance. And the idea is that, if they charge us for some of our care at the point of care, then we're going to use less care. The problem, though, is that we don't really know when we're going to get sick because none of us actually expect to get sick in the future. And if we do, right, then the cost of that is going to be higher, and insurance is going to do everything they can either to push us off the rules or to force us to pay as much as possible of that. And so what happens when we want our care is that we're not really the consumer of the healthcare. We're not the one who's paying for that healthcare. Instead, we're the reason why a financial transaction happens between the insurance and the provider. We're not the buyer of the kohlrabi in that analogy. We're the kohlrabi itself. We're more the product. And that becomes a serious challenge. Now, these industries, they have a real incentive to make as much money off of that financial transaction as possible. Because in effect, right, they are all for-profit operators and are interested in maximizing their profit margin, which means, right, that overall, the price of that care, right, is something that they both profit from, which means that they have an overall incentive to raise that price. And so we end up being a very expensive product indeed. And more of the cost of that gets pushed back, ostensibly back onto us. And we'll talk a little bit more about that, I hope, in the discussion. So when you have a set of transactions that is costing more and more of the system, you create two problems that, in effect, stop us from preventing care. The first is that the system benefits when people get sick, right? That is a fundamental political economic truth of our healthcare system, that stops us from really investing in prevention. It's really hard to monetize prevention. I'm trying to sell someone on the idea that they're not going to get sick in the first place. When you can't specify who's not going to get sick, from what disease, and in what period of time, becomes a very difficult thing to do indeed. And in fact, we are not doing that thing in America because there's too much money invested on the back end of people getting sick in the first place. And the second is that even if we were able to engage with the resources to do that thing, the money lines up in the wrong pockets. So you could argue that insurance has an incentive to keep us healthy. The problem, though, is that there are about 700 different insurers in this country. And they know that the high probability is that by the time their investment in your well-being has actually panned out, you're going to be on a different insurance if you're not on Medicare, right? Which is the federal public insurance provider for people over the age of 65. So why would they invest in preventing your illness when that's going to accrue to Medicare? So even if there was a real incentive to keep you out of the healthcare system, which I would argue from a political economy standpoint, there's not. In the end, there's the wrong pockets problem. The money accrues out of that prevention. The money they would save from preventing your illness accrues to the wrong pockets. The second question then becomes, why does it cost so much? Well, if we are a transaction, right, we are a product in this system, then in the end, there's a lot of incentive to make more money off of it. And what's happened, actually, one of the byproducts of the Affordable Care Act is that the amount of money that any insurer could make off of a particular transaction was limited as a proportion of that transaction. And in effect, if you want more pie and you're limited to a particular percentage of the pie, you just make the pie bigger. And so there has been this increasing cost of prices, which occurred well before the ACA, but hasn't really been addressed by the ACA because of this unintended consequence of the policy. And when more and more folks are profiteering off of that pie, the pie is going to grow. And then ultimately, we're in a position now where what is the politics and the policy of doing it? I wrote a book called Medicare for All, A Citizen's Guide. As you guessed, I believe in Medicare for All. And what is Medicare for All? Medicare for All is a single government health insurance program that would provide health insurance for every single American, free of deductibles, free of copays and coinsurance, as it's written in both the House and Senate bills, that would guarantee every single American access to affordable healthcare. And by creating what's called a government monopsony, right? We all know what a monopoly is. It's a single seller of a good who gets to control the price. A monopsony is a single buyer of a good who also gets to control the price. And in creating a government monopsony, we could control the prices of healthcare, reduce the prices for everybody, reduce the overall cost of healthcare by eliminating a lot of the overhead in our healthcare system, and thereby being able to afford healthcare for everyone in a system that's ultimately less expensive than the broken system that we have right now that has a ton of holes and leaves us sequestering more and more money into the system. Personally, I come to healthcare policy from public health. I grew up in a public health system. My first public health mentor was Dean Galea. And I come to this asking question number one, first and foremost: why don't we invest in population health? And my argument to you, right, is that the single greatest reason why we need to address our broken healthcare system is so that we can finally get to the work of improving population health and investing upstream. And Medicare for All will allow us to do that because the government would be our insurer today and tomorrow, and we'll have been insuring yesterday. So any investment that is made in our well-being over the long term accrues to the same pocket over the long term, which creates that incentive to do that thing. Now, the politics are hard. We have a Democratic president, sure, but we have a president who does not support Medicare for All. And folks would say, well, we had two now Democratic presidential elections where the debate about Medicare for All was had. And that has ended up in one Republican president and one Democratic president who doesn't support Medicare for All. Why do you think we can do this now? And I'll push back and say that actually the movement for Medicare for All is stronger than it's ever been. We go through great links in the book to talk about the history of health reform in this country and the efforts that the healthcare industry has put into defeating it. But right now, we have a situation where the majority of Democrats are co-sponsors on a bill, majority of Democrats in the House are co-sponsors on a bill for Medicare for All. And we are in a position where Medicare for All and single-payer healthcare are truly household ideas that people talk about. and that the nature of the industry and the greed of the industry has gotten so profound that finally this is no longer a conversation about how we provide healthcare for low-income people. Instead, it's a conversation about how we provide healthcare sustainably for everyone. And this is the moment where I think that we build power for Medicare for all. In the end, in order to get there, right, we are going to have to organize, and that comes down to opposing the moral force of an industry that has spent billions of dollars now, both lobbying our politicians and also advertising what is ultimately, I would argue, disinformation about the nature of our healthcare and what Medicare for all and or health reform would do in the first place. And that will mean doing the grassroots work of coming together to find ourselves in this conversation about healthcare and to find each other in this struggle. And so this is implicitly a political conversation, and one that I think the politics of which we have to embrace. And I'll finish on a final note. I know we're at a school of public health and we're having an academic debate about public policy for public health. But in the end, health is a scarce resource. COVID-19 has shown us that not everybody gets to live a long, healthy life. And I think COVID-19 in particular, right, for those of us who've been steeped in this conversation for a long time, we knew what the outcomes of this pandemic might be. We could have predicted them. But I think COVID-19 have put them on public display. And if we know that a long, healthy life is not, the access to that thing is not shared equally for everyone, we also know that politics is the set of decisions we make about how we share scarce resources. If health is a scarce resource, health is implicitly political. And so my argument to you is that we have no choice except for to embrace the politics of health. And I don't mean capital P politics. I don't mean partisan politics. I don't mean red team, blue team, Democrat, Republican, although I have my opinions about that too. But what I mean is that this is implicitly political. And if it is, then we have to decide, how do we operationalize the politics of health? What are the debates that we jump into? How do we jump into them? Where do we bring our science, and how do we connect that to smart storytelling that gives us the anecdotes behind the data, the anecdata that make this real for people? How do we communicate in ways that transcend the empiricism that sometimes can get really opaque for folks and put it in really stark, honest terms? And how do we do that in a way that hopefully transcends partisanship, but brings our values and our goals forward and operationalizes them within the politics that we have, or ideally transforms the politics we have so that it's built around this ideal of well-being. So I look forward to this discussion. I'm really grateful to be joined by Professor Garrido, whom I know has been studying this throughout her career, and look forward to the questions that folks may have. Thank you.
Thank you for that great overview of the topic. While we're waiting for some questions to come in from the audience, I have a few of my own, and just want to perhaps ask a few questions just to make sure that the audience has a little bit more background information. So, not saying that price is the only consideration, but a lot of the arguments for a Medicare for all plan state that it will be cost savings. Could you walk the audience through some of the mechanisms by which Medicare for all might save money?
Yeah, let me quickly just change my sound, just simply because I think that people are having some trouble hearing. You guys still hear me okay? Yeah?
I can.
Okay, good. So cost savings under Medicare for all. So first of all, when we talk about cost savings, there are objective parties that have looked at the potential cost savings. The Congressional Budget Office, which is sort of seen as the nonpartisan cost watchdog, has scored Medicare for all and demonstrated that in fact it would cut healthcare costs, and that would happen in a couple of ways. First, you have the overhead of our healthcare system. So, I shared that, healthcare is basically this set of transactions between payers and providers. And if you sort of think about them as this group who negotiates prices together, but really is incentivized to be negotiating not against each other, but against their competitors, you have this scenario where you end up heading toward not just a set of sort of localized monopolies, right? but that tends to make sure that both of these folks are eating well at the end of the day. The other part of that is that because there are multiples across each of these, there is a tremendous amount of overhead that exists across each of these sectors. So the first cost reduction is in that overhead, that you are, instead of having multiple different payers, you have one payer. That's what single payer means. And so rather than having to figure out how to crosstalk with a whole bunch of different insurance providers, each of them with their own overhead, their own CEO who's commanding millions of dollars in salary, their own advertising costs, their own billing system, you only have one, and that's the government, right? And we know that the overhead in any one insurer is about 15%, whereas CMS, the Centers for Medicare and Medicaid, run Medicare at about a 3% overhead. So when you go from multiple different overheads that each themselves cost a certain amount of money, plus require every single provider to be able to bill a certain number of insurers, to one that operates at 1/5 the overhead of any single one of those insurers, you end up eliminating a whole lot of overhead, right? And so that comes in the form of billers and CEO pay and advertising costs. So that's one source. The second source, though, is the capacity to have a government monopsony, right? We have this increasing price schedule that happens because of the negotiation between these two industries. But in becoming a monopsony, the government basically gets to set the price, and it would set the price substantially lower for any given care, whether that's an MRI or the aspirin that they give you at a hospital, substantially lower than it is right now, because we know that our prices are inflated. We talk a lot about why healthcare is so expensive in the book, and ultimately it's not because we use more healthcare, it's because the prices for our healthcare are so much higher. So if you can set prices to be lower, you can do a lot to reduce the overall costs. So those are the two biggest sources of cost savings under Medicare for All. The other piece of the way to think about costs here is who bears the costs. And right now, our healthcare system is extremely regressive. What do I mean by that? If you're poor in this country and you have healthcare, you have private health insurance, you're paying substantially more as a proportion of your salary than someone who is higher income, in large part because we don't ask corporations to pay as much, and because our system in this country tends to be regressive so long as it's private. Under Medicare for All, you get to decide, right, what proportion of the tax that would go into paying for Medicare for All gets paid by whom. And so, for the median American, and certainly anyone who's earning less than a median American, their healthcare costs are going to become substantially less expensive because of progressive financing. And so the lived experience of cost for the median American on down is going to be substantially lower. And actually, most of the models have shown that even for folks who are earning six figures, if they're earning in the low six figures, their costs don't go up either. And so because you're reducing the overall cost and you're progressively financing what's left, you're now experiencing substantially lower costs and lower prices for care, and therefore for insurance. It comes out in a different way. Rather than having to pay a premium, a copay, and a deductible, you're paying a tax. But that ends up being substantially less in terms of your overall healthcare budget.
Right. Thank you for that. Let me push you on that a little bit. So part of the way that you would reduce costs would ostensibly be to reduce payments to providers, make them closer to Medicare rates. And there's a strong assumption that administrative costs would go down. But at the same time, we're taking away some of those other places where providers might make up some of the deficits in payment from Medicare rates. The program would be expanding to cover millions more people. How much do those differences in the estimates affect the viability of a Medicare for All plan?
It depends on who you're talking to and what assumptions in the current system you're willing to bear, right? You think about where healthcare costs are spent in our system versus a single payer system like Canada or a single provider system like in the UK. And we're spending a lot more on things that don't necessarily add value. Now, if you talk to a physician who's, let's say, a primary care provider or a psychiatrist, they'll tell you that under Medicare for All, where you can set prices, and so you in theory could invest more in those kinds of care because they add substantially more value, that they'll be just fine. If you talk to a orthopedic surgeon or a dermatologist, right, who are making substantial amounts of money on the system, they'll tell you it's impossible. My argument, though, right, is that rather than map to a completely oblong system that we have right now, we ought to be mapping to what we actually want. Now, the transition is something that you have to really be thoughtful about, and how you transition from where we are right now to where we're going ought to be done in a way where you're preserving people's livelihoods, and you're being really thoughtful about how you protect and move people equitably through that transition in status quos. But you're spending a lot more now on things that really do provide the kind of value that we'd want in the system. The other thing I'll say is that one of the challenges with the system that we have now is it has led to a very corporatized healthcare delivery model that has been deeply unsustainable for providers in particular communities. So if you're an urban provider and you're an urban safety net hospital, it's become very, very hard for you to survive, because so much of your reimbursements are Medicaid if your care is reimbursed at all. And particularly in rural communities, right? This has become an epidemic of hospital closures. So we saw 12 hospital closures and 35 bankruptcies of hospitals in 2020 alone. This in the middle of a major pandemic. So I'd argue that the sustainability of our current system to provide healthcare for people who fundamentally need it is very limited. And Medicare for All could become a lot more sustainable for those folks who may lose healthcare, not because they're not insured, but because there just aren't healthcare institutions near where they are. And that's something that we've got to be thinking about as we think about what a transition looks like. One approach that the recent House bill proposes, that Representative Pramila Jayapal, who's been a real champion for Medicare for All in the House, is a real proponent of, is a global payment system. So rather than paying in a fee-for-service model, which is basically you do a certain amount of healthcare, you get paid a certain amount, which tends to incentivize just more throughput rather than value-based care, and tends to fail these either low-density or high-poverty communities. You just pay a hospital to provide healthcare for people who are there at some lump sum value, and that may have to be the way that we provide service, or we provide payments for rural healthcare institutions, and that can't be done through the current system, right? You'd have to be negotiating how many different insurance lump sum payments that just can't be done. And so, I'd argue that Medicare for All is actually fundamental. It's critical to keeping rural and urban hospitals open.
Thank you. One other piece about sustainability, you mentioned long-term care briefly in your book, and I'd like you to expand a little bit more about how financing of long-term care through a Medicare for All plan might be done. If it replaces Medicaid, that has huge implications for how long-term services are provided. I know the various proposals differ in how they handle this, but what would you say about that?
Yeah, look, long-term care is not only potentially one of the most expensive line items in healthcare, it's also potentially the fastest growing, just as a function of American demography. But it's critical, right? And in long-term care is I mean, the statistics on this are wild. The number of families that are stuck, trying to provide long-term care in an ad hoc way because we don't provide it in our country. The amount of labor that is provided unreimbursed, the impact that has disproportionately on women and their accessibility to the labor market when they are in effect forced to provide healthcare or care at both ends of the demographic spectrum, to children and to seniors or parents-in-law. It is absurd. And so we have to figure out how to provide long-term care in some way. We've frankly been punting on this problem. When you decide that a viable and sustainable healthcare plan has to include long-term care, it automatically expands the cost of that. And we touch on it because we think it's the right thing to do from a justice and sustainability standpoint. But the fact is that the fact is that we sometimes conflate the conversation about long-term care with Medicare for all, because in theory, we should be providing long-term care through Medicare as it is right now, today, right? And so, the reason we don't do that thing is because people are afraid of the price tag. And so my sense is that we should decouple these conversations and talk about providing long-term care as a function of Medicare as it stands, and then also talk about it in the context of Medicare for all, because it's the right and just thing to do. Ultimately, this is going to be super expensive, and we have to decide that it's worth doing. I mean, I don't really know that there's any other way around it, except for that we're getting older as a population. Our seniors are struggling, and people are struggling because of it. And if we don't provide long-term care, what it's going to mean is that we have a deeply inequitable access to this thing. And, that has long-term implications for family wealth building. So if you're in a low-income family and now, usually a woman, right, because of our misogynistic gender norms, are forced out of the labor market to care for seniors and children, that means the wealth contribution and the long-term outcomes for that individual, but also that family, are hurt by it. Whereas, higher income families who can afford long-term care insurance get that thing, people can stay in the workforce, and it just multiplies the differential across them. So I think it's a separate issue for Medicare for all. It's just an issue for Medicare, and it's something that we ought to do. And yes, it's going to vastly increase the cost of our public entitlements, but I think it's something that we ought to do because it's the right thing to do.
I think you're absolutely right that regardless of whether Medicare for all goes forward or it's some other health plan or current health system, it's a very important problem, and it's currently subsidized by unpaid family caregivers, so that any actual coverage of long-term care will really be expensive, but necessary. Changing gears just a little bit, I'd like to hear your take on kind of the politics and the feasibility of getting something passed in our current political climate. We have the recent House bill for Medicare for all. How does the role of the filibuster or budget reconciliation, how does that all play into what's actually possible right now?
Yeah, I don't believe we're going to get Medicare for all under a Biden administration, whether that's, another 4 years or 8 years. He's not for it, and he's made that very clear. Obviously, I believe that he should be for it. All right. A lot of the debate about Medicare for all was contested in a pre-pandemic moment, and we're all obviously living in a post-pandemic moment. I had the privilege of serving on the task force that helped to write the Democratic Party platform, and I was appointed by Senator Sanders. 3 of 8 of us were, and the other 5 by then Vice President, now President Biden. And we debated quite a bit about what ought to be done, and that was in June of 2020, when the pandemic was only 3 months old, right? And the economic consequences of that hadn't fully played out. I think what we've seen, right? There was a conversation, there was a debate then about whether or not the pandemic-induced recession would be a true recession, or it would be a vastly unequal recession. And I think what we've seen is, a truly K-shaped recession. If you are a professional in this country and you've been able to work from behind a computer screen, you've actually done pretty well, right? I mean, there's like the housing market is extremely hot right now, driven by people who are stuck at home and want a bigger home, and also have the money that they haven't been spending on vacations and eating out to be able to invest in that, right? And so if that and interest rates are super low, that is one experience of COVID-19. The other experience of COVID-19 is that you and your family who rent are in a situation where you got more and more people in a smaller and smaller home because people are losing their income substantially. And even among those who have been able to work, that has meant a added risk of COVID-19. This hasn't really been costed out, but like, I'm really interested in understanding what the economic consequences of lost people are in low-income families, because I just don't think we've even looked at that. And one of the scariest numbers that came out, right, for folks who sort of think about what this means, is that those life expectancy numbers that came out that showed that we lost on average a year of life expectancy in the first half of 2020. The crazy thing is that if you were a Black man, you lost 3 years of life expectancy. That's not just because of added risk of COVID-19 or death from COVID-19. That represents earlier death from COVID-19. That means that is less time in the potential workforce among a subset of people who are substantially vulnerable to economic shocks. So I just don't know that we fully captured what the economic consequences of that are going to be. So what does this have to do with healthcare? As we think about where the Biden administration has to work, right? The question is not just a healthcare one, it's an economic one. And one of the most important things that health insurance was created to do was to insure you against the economic shock of illness. And our current system has just fundamentally failed to do that. It's failed to do that because it's introducing people in the midst of a pandemic to that shock. 15 million people lost their government health insurance. But also, right, because of the advent of things like deductibles and copays, which were just not a thing back in, even 2 decades ago. And where that leaves us is that I think the experience of this moment is going to create a tremendous amount of organizing and power building for Medicare for All. There is a lot of momentum in the House. You look at, the bill drop last week relative to even 2 years ago. You've got folks like Frank Pallone, who is nobody's progressive, who have signed onto the bill, right? Who is the chair of the Energy and Commerce Committee, who blocked the Medicare for All hearing in the last Congress, who's promised one in this Congress. So there's a lot of momentum that's moving in this direction. We're not going to get it in the Biden years. The question is, are we going to be able to build the kind of momentum that we need to deliver this in the post-Biden years? And I want to say a couple things about the nature of the politics here. I think we have confused ideology for partisanship in the post-Trump era. What do I mean by that? In the past, right, you look at 2014, 2015 in the Obama era, there was this ideological alignment in the parties. I think Donald Trump has molded the Republican Party so that it's not really a party of ideology anymore. It's more a party of identity, right? And that's white working class identity. And the reason that matters is actually really quite interesting. There was a poll done in 2019 that looked at how much support, and this is going to be mind-bending, so just bear with me on this. How much support would Donald Trump lose if he supported Medicare for All? And they found that he'd lose 2 points. Why? Because Donald Trump is a trusted deliverer, right, of white identity-oriented policy. And so if Donald Trump is for Medicare for All, right, then you can trust it. And what that tells us is that it's not about the policy, right? Ideology is not a real thing in the Republican Party anymore. You had this $1.9 trillion COVID-19 relief package, and rather than have a conversation about that, there was a conversation about Dr. Seuss and Potato Head, right? And so ideology is not the issue anymore. It's just partisanship. And if partisanship is now an identity-oriented issue, then the push for Medicare for All will be opposed simply because it's the other team who's pushing it, right? And I think we haven't really contended with that fact yet. Heather McGhee, who is an economic policy expert, wrote a fantastic book called The Sum of Us, where she argues that there has been a deep, profound cost of racism for white folks too when it comes to our public policy. And Medicare for All, right, is one of those general policies that would be available for everyone. And in 2016, the median infant born in this country was an infant of color. And so the trends of sort of identity-based partisanship and the economic cost of racism and the increasingly unstable insurance system are going to come to a head sometime. And the real question that I would ask folks is, what are we doing over the next 8 years to make sure that we are building a moment where Medicare for All becomes possible? Because if you look at the history of Medicare, which we talk about in the book, nobody saw it coming until it came. And it just took the right confluence of actors in the right moment, and the right movement behind it to make it happen. Very long-winded answer to your question, but I just wanted to try and dissect out some of the countervailing trends that I think are going to shape this moment and whether or not this is possible in the next couple decades.
That was helpful. Thank you. I want to turn now to some of the questions from the audience. We have quite a few that have rolled in while we've been speaking. So the first one is, looking around the world, we see a great variety of potential pathways to universal coverage. if, as you argue, Medicare for all is right for the US, is it right for all those other countries too?
So, this question is actually usually asked in the contrapositive, which is there are a lot of ways to get to universal health coverage. Why shouldn't we take the German model or the French model rather than the Canadian model? There are advantages to Medicare for all that that from a policy standpoint portend, I think, a far more parsimonious set of solutions to the problems that we face. And the reason why is this. It's the difference between having a patch quilt that has a lot of holes in it that is a little bit too short. And, at any given time, some part of your body is just not covered by the quilt and you're kind of cold. And, if you pull it up to cover your chest, your feet are showing. And if you pull it down to cover your feet, your chest is showing. You can't really quite get warm. And there's always a part of your body that's cold. You can sew more quilt onto that quilt, which is what the public option does. You can try and double sew the holes between that quilt and reinforce it. But the nature of a quilt is that there are weak points and that there are holes that are going to pop up. Medicare for all is like a felt blanket, right? It doesn't have holes. And because it doesn't have holes, it covers everyone. And if you make it long enough, right, it's going to cover your whole body. You don't really have to worry about it that much. It is a better policy solution because of the capacity for government monopoly to set prices, the ability to cover everyone, the incentive to invest in prevention. All of that makes it a better policy. I say this believing that the politics of it are possible too. Most of the time when the question is asked, it's asked because people have given up on the politics of it. They're like, this is politically impossible. So what other better patchwork can we invest in? And my point is like, well, if you want a felt blanket and you want everything to be warm, go get a felt blanket and work really hard to get there, right? It may also work this way. It may be the fact that the fight for Medicare for all finally gets us a triple reinforced quilt blanket. But the problem is that we're in a system where there's always going to be incentive to tear that back. We've seen that, whether it was the ACA, Jonathan Cohen wrote a great book also back here called The 10-Year War that talks about, the Republican onslaught to tear back the ACA despite all of the benefits. And my sense is that you want a system that has fewer holes to be exacerbated by people who just don't believe in, i.e. or sit on the other side of, universal government healthcare. And it is worth fighting for. So, that is sort of my reflection on the question. The last thing I'll say is that I don't know about other countries. I do know, I lived in the UK for a while, and I do know that the experience of getting healthcare, and it seemed like the experience of giving healthcare in that country were substantially better than the ones we have. But I don't know enough about other countries to be able to say whether or not I think single payer is the right solution for them. But structurally, I do think it's the right solution for us.
Right. Well, and maybe kind of a related question. I'm wondering about how far can we take this blanket metaphor? But maybe there's some benefit to adding on to the patchwork quilt while we're working on creating the felt blanket. But another question that has come in is, we all understand the ethos of Medicare for all, but how do we actually implement the seismic paradigm shift that would ensue?
Yeah. So to your first point, Melissa, I agree with you. There are some folks who, I don't know what it is. Maybe they think about healthcare as being this abstract thing, but like I've been in too many clinics, and I've worked in public service, and there are real people on the back end of these problems, and we can never lose sight of that. And any effort to expand their healthcare, to reduce the power of corporations, to increase the public footprint, to make health insurance a little bit more sure is worth pursuing. I want to be clear about that. And so, we can walk and chew gum at the same time. And I sometimes use a football analogy, so pardon me for the sports analogy, but you can kick a field goal and then come back and try and score a touchdown. You can do both of those things, and I think we ought to, right? Because the whole goal here is to win the game. To the question that was asked, refresh me on the question just to make sure I'm answering the right one.
How do we actually implement this seismic paradigm shift?
The transition. So there are two countervailing forces that that exist in this sort of transition period. One is policy and one is political. The policy transition, the incentive there is to move as slow as possible because, of course, we all saw what happened with healthcare.gov. You cannot be hasty because this is such a huge transition, and it is a major, major transition. Most of all, right? It's a transition in jobs. There, on the one hand, there are a lot of jobs that potentially, if we're not thoughtful about them, could be lost in the insurance industry. Although I think that argument is sometimes overblown because you still need a substantial amount of bureaucracy to provide healthcare for everyone. In fact, I would argue you need more of it because there are 10% of people who you're now including in the system that had been excluded. And then not only do you need to provide them health insurance, which is cause for a lot of bureaucratic jobs, but you need to provide them health care. And we're already facing a lapse in the amount of health providers that we actually need to provide healthcare today. So training up the number of nurses and doctors and healthcare workers that will need to serve 10% more people is really a big push. At the same time, on the other side of the policy, right, which is would have you moving as slow as possible, there's the politics. And the hard part about the politics is that every single time the American public have been given access to a public resource that is provided by the federal government to everyone, they have liked it every single time, right? Medicare, Social Security, the ACA, right? And, the GOP understands this, and so we'll fight tooth and nail to derail reform before the benefits hit the public. And so for that reason, the political transition has to be quick, right? Because you don't want to be in a situation where you're halfway to Medicare for all, there is a change in party, and then you never fully carry out the transition. And so it is the trade-off between the politics and the policy that gets really naughty. My sense of it is that you want to be able to carry this out within one administration. And the reality of it is that any administration is its strongest the day it takes office, and its power starts to loosen after the first 100 days, and then usually after the first midterm election, they've lost their majority in the Congress. And so you really want to be able to pass this legislation immediately, as soon as you possibly can, and then spend the next 4 years implementing it and be done with the implementation within 4 years. And that is, I think, the best balance between the policy reality of this and the political reality of this.
Thank you. And kind of on a related note, could you discuss the advantages or disadvantages of political action to establish single payer at the state level as opposed to the national level, perhaps by expanding Medicaid programs?
Yeah. So, I've actually increasingly come to believe that the right way to implement Medicare for all is actually as Medicaid for all. What do I mean by that? Is that rather than processing one transition from CMS that provides Medicare to everyone 65 or older and folks with certain disabilities, you're now providing for everybody. That's a really big jump. Instead, it's possible to just parallel process this and have every state, right, create its own system. There's a lot of sort of local control that can be leveraged there. At the same time, we saw what happened with Medicaid expansion and the fact that you still have a large swath of the South that hasn't expanded despite themselves, and there are real risks there. I do believe that state level single payer, I think we're going to see a state level single payer reform before we see a federal single payer reform. I think it's probably going to come out of either New York or California, where there are really active movements there. In fact, the New York Health Act has support from the majority of the Democrats in the state legislature, and it has real legs, and I think could really pass. There are some challenges to state level single payer reform. The first is state governments by law can't sustain debt, right? They can't carry over a debt year to year, and so you have to balance your budget every year. And when you're transitioning into providing healthcare for every single person in your state, that's really hard to do without federal government backstop. The ACA provided for a series of or a system of waivers that could potentially empower CMS to offer waivers on the way that a state uses Medicaid or Medicare dollars, which could provide that federal backstop. The other challenge is ERISA, which is a law that basically preempts state level regulations on the way that corporations provide benefits. And this would require, state level Medicare for all would require states to rethink the way that government or that corporations pay for those benefits, because basically it would be asking them to pay a tax instead of paying for those benefits for their workforce. And that could also pose a real challenge. That being said, these are all workable. They just require some real, I think, federal government partnership. So the idea that a state could just go it alone without the federal government being there and supporting is hard. At the same time, President Biden ran on a platform that empowers states to pursue these kinds of single payer reforms. And there's real potential that the federal government could work in that direction. We know that the newly confirmed Secretary of HHS is a Medicare for All supporter, Javier Becerra. And so, it would likely be, obviously with the tacit approval of the president, but it would be the secretary making those decisions. And so, I think there's real movement is possible there. And, history serves us a really great precedent. In Canada, when Canada passed its ultimate single payer reform, it had been on the back of several provinces being led by Saskatchewan to do this thing. So this sort of federalized, or excuse me, this localized approach in a federalized system has real precedent to it.
Definitely. Changing gears a little bit, another question from the audience. Hospitals and physicians have historically been the biggest opponents of health reform, and it doesn't seem likely that their political clout will change after spending the past year fighting COVID-19. How would you say we can get the healthcare industry to be partners in the fight for Medicare for all?
So I would actually say, you look at the largest nurses union, they have been on the right side of this the entire way. You look at the SEIU, who represents the largest number of hospital employees, they've been on the right side of this. It's doctors and hospitals. And I do want to say, I was of one mind about how hospitals work, but now I think I have changed my perspective. It's largely driven by my co-author, Dr. Micah Johnson, who showed me light on this. There are a lot of different kinds of hospitals. And when you're talking about safety net hospitals and teaching hospitals, they're often on the right side of this because the current system does not reward them for the kind of service that they offer, because a large proportion of their patients are Medicaid patients. And so their reimbursements are substantially lower. So they actually do support oftentimes single payer or more progressive approaches to providing healthcare. Doctors have changed substantially, and that's in large part because I think, in the past, physician power has declined. And there's a great book by Dr. Sandeep Jauhar called Doctor, where he argues that physicians went from being knights of the healthcare system to being knaves of the healthcare system to being pawns in the healthcare system. And that's largely correct, as corporations have increased power in the system. And part of that is because of the way the system works right now. You have the capacity for larger providers to command better reimbursement rates than physician-owned practices can. And so what happens is, because they can command better reimbursement rates, better pricing from large insurers, they end up outcompeting these smaller practices and then buying them up. And so whereas doctors used to be owners of businesses and used to organize as a guild, which is what the AMA actually is, now they are more employees in the system, and there really hasn't been a great organizing tool around them. And I think, in some ways, I think physician hubris here has been part of the problem, is that a lot of physicians don't see themselves as, workers who ought to organize in a union, and instead sort of still see themselves, because they're high income workers, see themselves as independent and autonomous, and nothing could be further from the truth. And so when you look at where physicians are, the truth is that in 2018, the median physician supported single payer healthcare, and that has just grown over time. It's also interesting that in 2018, the median physician no longer worked for a physician-owned practice. They worked for a large healthcare corporation. And so I think as physician power has declined, as physician labor has changed in nature, you're also seeing physician preferences around healthcare change as well.
Great. I'm going to combine several questions here from the audience into one paraphrased question. Several people are wondering about what kind of services would be covered in a Medicare for All plan. Vision, dental, what's the role of specialty care or maybe somewhat elective procedures?
Yeah. The right way to think about Medicare for All isn't like Medicare as it is for all. It's more improved Medicare for all, because there are a lot of holes in Medicare as it is. One is that it doesn't cover dental care. It doesn't cover optometrist care. It doesn't cover auditory care. And I mean, these are big holes for seniors, right? You think about the fact that Medicare doesn't cover hearing aids, and that's just kind of an absurdity. On top of that, the way that the system works, where you have all these different parts and almost requires Medigap coverage to actually get full coverage, is a real problem. And then you have the predatory system of Medicare Advantage, which cherry picks the healthiest patients and then profiteers off of that for private corporations. And all of those, I think, are big holes in the current Medicare system. So Medicare for All, as it's been articulated, both it sort of had three main articulations: one in the House bill, one in the Senate bill, which is not identical but very similar to the Medicare for All that Senator Sanders ran on in 2019, 2020, and then one in the Elizabeth Warren policy platform. Senator Warren's platform was a little bit different than Senator Sanders' platform, but also a Medicare for All plan. All of them have covered vision, hearing, mental at parity, right? So with the same kind of coverage as physical healthcare, and then auditory and visual healthcare, and all of them have been zero deductible, zero copay plans, so zero out of pocket. And importantly, in the Biden plan, the task force plan that we proposed and that Joe Biden ultimately ran on, would force a zero deductible public option, right? Which is also a pretty big deal, heavily subsidized. But that's the way Medicare for All is envisioned. We talk about some of the ways that these policy choices get politicized, right? When you talk about long-term care, when you talk about care for transgender people, when you talk about care for immigrants, like all of these things are going to be deeply politicized. And my hope, right, is that we would pass a Medicare for All that is truly inclusive and offers the full gamut of healthcare that any and everyone would need. But we also know that as you sieve these through the political process, as support, for example, for women's healthcare and reproductive healthcare has shown us, is that there are exclusions that get made. And so, the question of what Medicare for All offers is really a question of what are we willing to fight for, and that's what would make it into the final law if and when it passed.
Thank you for that. Several audience members also are asking about the impact of Medicare for All on choice. So one question here is, I understand the cost and overhead aspect, but most important to me is being able to choose my provider, schedule an appointment with my provider, and select healthcare organization or provider of choice. How would Medicare for All impact my autonomy in choosing or selecting a provider?
Yeah, well, the thing about it is that if you have a single payer, it tends to force every provider to take that single payer, right? I mean, very, very few providers who care for seniors who don't take Medicare, even if the reimbursements are lower, because it is such a dominant provider. And Medicare for All would do the same thing. So, the interesting thing about the way the system works is that they tell you that Medicare for All would take away your choice. Well, yes, it would take away your choice between which large corporate insurance bureaucracy are you interested in giving money to, so that they can tell you what doctor you can see. But when it comes to the choice of doctors, right, the single biggest gatekeeper around your choice of doctors tend to be those insurance corporations who, in theory, you chose. And so the question of choice actually gets expanded under Medicare for All because of the fact that your insurance is accepted everywhere by every doctor, and there's no real incentive to limit which provider you can you can go see, because there aren't special, opaquely negotiated deals about pricing between the provider and the payer.
How about wait times for appointments? Several audience members have asked questions about whether this would impact the ability to access care. Would we have to wait a long time for a surgical procedure?
Ultimately, there are two ways to answer that question. It depends on what procedure, right? If it was life-saving care, really, arguably, those wait times would probably go down. But if it was elective procedures, it really depends on how generous do we want to be with the system, right? Because in the end, what the system can afford is a function of what we pay into it. And the hard part about the way that these systems get sieved out is that ultimately, after they get passed, there is a political incentive on the part of people who are ideologically or politically opposed to make the system as bad as possible, and then point to it and say the system is failing, we have to reform it. And that's what tends to happen with government services all the time. So we point to government services and say, look how bad this is, where they're actually performing, substantially more efficiently than private services, but they're just underfunded. And so they're unable to sustain because they've been underfunded as a function of political warfare. And so the question of wait times is really a question of how generous do we want to be with the public system? And if we are generous with it, if we are investing in it in the way that it deserves to be invested in, if we're spending 18% of our entire economy on it, it's, you can get those wait times down pretty low, and you can have a really effective and inefficient system. But if we are systemically underfunding it, if we are pulling from the funding sources from it to pay for other things, that's when wait times will go up, et cetera.
Right. And a couple of other audience members have asked related questions about the shock that that Medicare for All might have on people who are working in insurance industries, who are working as healthcare administrators. You've touched on this a bit, but maybe could you expand on how you might stage a Medicare for All rollout so that we're not laying off thousands of people who were working for the private insurance industry?
Yeah, that's a really important point. And the goal here would be a just transition. And what do I mean by that? For folks who potentially would be at risk for losing jobs, that there are other jobs that are available to them, and that if there is training required to get those other jobs, that training is not just paid for, but that they are paid as they are pursuing that training. I actually think that that's one of the most important things. The other part of it, though, that we sometimes don't pay attention to is the moral cost of the system that we're in right now. When I was campaigning for governor in Michigan, I met a woman who pulled me aside after one of my events, and she said, all these things that you keep saying about the insurance industry are true, and I want to tell you my story. And she said, I used to work for one of the biggest insurers in the state, and I worked for them until the day I was forced to deny a woman who was on the verge of bankruptcy, who needed care for her breast cancer, to deny her reimbursement for her care. I knew that at that point, not only had I denied her the care that she needed for her cancer, but I had probably put her family in bankruptcy. And I resigned that day, and instead I went to nursing school, and today I take care of patients with breast cancer. We don't appreciate the fact that the way that the insurance industry makes money, by definition, is by taking money that people have paid for to give them health care and using it as profit, right? Which means denying them health care if and when they need it. That is a fact of the system. There is no denying that fact. And that's just not a great way to make your money. I mean, I was always astounded when I would get contributions when I ran from people who worked for health insurance corporations. And they'd send me these notes being like, hey, I know you really, really want to change the way that my system works. And I agree with you. So on the one hand, we will need a lot of healthcare administrators in a Medicare for All system. It's not like people aren't getting insurance. In fact, more people are getting insurance. What goes away for the most part tend to be the ancillary parts, right? Tend to be, the marketing budget, tend to be the CEO salary, right? Tens of millions of dollars for many of these insurers. And what tends to stay are the people who are needed to facilitate care. That being said, because there is one biller, one payer, a far larger payer, but one payer, a lot of the provider side billing will likely go away. My hope, right, is that we're really thoughtful about architecting a pathway toward a transition where these folks now have jobs providing the healthcare that 10% more people need. That is going to have to be how it works. And we have to be really, really thoughtful about building great programs. The hard part about this, right, is that this is a similar challenge that we face almost across the board when it comes to addressing some of the structural failures in our economy, whether it is healthcare or it is climate change, right? Similar question about how do you architect a just transition away from a fossil fuel driven energy industry to a renewable driven energy industry. That means if you are working in coal, right, that job probably goes away, but how many jobs do we create, right, in a creating solar power, right, and or wind power in ways that are far more sustainable for all of us. And this is a question that we have to get really good at answering as we try and move our system away from these systems that are creating net level harm and towards systems that are creating net level benefit.
Yeah, absolutely. One of the things we haven't really touched on very much today is pharmaceutical pricing. Some of the Medicare for All plans would include some regulations on the prices that could be charged for different drugs. And a few of the audience members have been asking how Medicare for All might affect our ability to advance technology or advance, pharmaceutical innovations. What would you say to that?
Yeah, well, first, when it comes to pharmaceutical pricing, we don't need Medicare for All to solve our pricing problem. We just need to empower Medicare to do the thing that it ought to be able to do, right? If it weren't for the fact that the pharmaceutical industry has spent $4.4 billion lobbying our politicians over the past 20 years, billion with a B. Here's the thing though, right? Think about the COVID-19 vaccine. It's the perfect allegory for the way that the pharmaceutical industry works. Government invests huge amounts of money into private industry to allow them to do a thing. And then private industry figures out how to profiteer off of that government investment, right? And we're starting to see that, right? Sure, yes, our government has bought enough or access to enough doses to vaccinate everyone in our country. But now the question is, well, how do we vaccinate everyone everywhere? Because of course, this is a global pandemic and every warm body that remains unvaccinated creates a evolution opportunity for this virus to potentially slip by our vaccine-mediated immunity. And the biggest obstacle to doing that, right, is pharmaceutical patents that were paid for by government. And so, you look at the 254 different prescription drugs that have hit the market over the past 10 years, every single one of them at some point benefited from government funding. And so, so long as we're investing in the NIH, which I hope we will continue to do at a greater level than we are now, we will be able to invest in the kind of innovation that creates new medicines. And that's a good thing. But, right, I don't think that we require a set of industries whose principal goal is to profiteer off of them, to be able to set the terms for the debate about what the prices ought to be without any government opposition whatsoever, which is what we have right now. And so, I just think that we have to get right on this issue. I mean, the politics are there. The Biden administration ran on equipping Medicare with the capacity to negotiate prescription drug prices for everyone. I think that is going to probably be the first big healthcare fight that we get in this administration, just because it's such a hard issue to oppose at this point because prescription drugs have gotten so ridiculously expensive. that I actually think that this will be a null conversation by the time we actually have a conversation about Medicare for all.
Well, let's hope we solve that problem, at least in the near term. A related question that's been coming up as far as prices and motivations. How would a system like this affect providers' salaries, and how do we maybe even out salaries a little bit so that we are able to get the types of providers that we most need to care for people?
Yeah, well, that's the thing, is that right now we spend so much money providing these tertiary and quaternary services. You can make a tremendous amount of money as a dermatologist and orthopedic surgeon, whereas earnings for psychiatrists and internists and family practitioners are still high relative to the median earnings in this country, but are relatively pedestrian by comparison. The choice of how we reimburse in Medicare for all is just that, it's a choice. And that's one of the nice things about the system, is that it gives us the ability, it gives us the control levers to be able to reimburse services for family practice and for internists and for psychiatrists at rates that are far better relative to specialists. The other thing I'll say about that is, one of the big challenges that we have right now is just the cost of medical education. Frankly, it is a bigger issue than even just the specialty choices that graduating physicians make. It's also an equity issue, right? You look at, we wrote a paper, actually, Dr. Goulet was one of the co-authors on this paper, looking at the differences in medical student debt by race. And we know that Black kids, because of structural racism, are forced to take far bigger loans and pay those loans down. And so, the choices that they face on the back end when they have to pay those loans is a big one. One of the things that Medicare for All could do, right, for a substantially lower proportion of cost than we expect, is just to pay for medical education. Honestly, why not, right? And that way you are buying providers out of that choice of having to say, well, do I go and fulfill my dream of taking care of low-income patients in whatever rural or urban part of the country, or do I become an orthopedic surgeon or a dermatologist to make more money back because I got to pay down my loans? And imagine we didn't have to do that thing. So I do think that this is a piece of that pie that we also ought to be thinking about. The other one is torts. There's no reason why Medicare couldn't become not just the insurer for people's healthcare, but the insurer for physicians' legal costs. And in doing that, right, it changes a lot of the decisions that get made in the interstitia of the system in ways that allow doctors to be doctors again without having to worry about whether or not they've written a note that perfectly covers their rear end for every interaction that they have.
Thank you. And just one final question before we hand it over to Dean Galea. You mentioned in your book and earlier in your opening remarks that what we really need to do is be organizing to try to pass Medicare for all. In just a couple of sentences, what advice would you give to people to actually do that organization?
Yeah, well, I really appreciate that. And we have a whole chapter in the book called Organizing versus Advertising, because this is what the fight's going to come down to. I think sometimes we focus on big capital O organizing. I'm working with so-and-so organization. And those organizations are great. There are organizations all over the country that are doing amazing work. And I hope that you will get involved with them if this is a fight that you're passionate about. That being said, there's also lowercase o organizing, right? Which is, having conversations with your friends and loved ones about our healthcare system and creating a space where they find themselves in this conversation in a way that they hadn't in the past. And I think that's really, really important, right? To be just having those discussions with people in ways that allow them to appreciate why the system has become such a burden on so many people, and to clarify that for them and help them to see themselves in the broader conversation. One of the things that we want to do with this book was ironically, take the discussion out of our politics and put it, at kitchen tables across the country, and help people to situate themselves in this discussion so that the next time this fight becomes political again, right, people see themselves in the fight in ways that isn't just red team, blue team, right, progressive team, center left team. It's, I want the system to work better for myself and my family and my loved ones, and it could. And this is how, and this is why I'm going to go out and knock those doors or make those phone calls or send those text messages, because I care deeply and passionately about this issue and want to see it change.
Right, thank you for that. And thank you, Abdul, for taking the time to speak with us today and answer audience's questions and my own. I'm going to turn it back over to Dean Galea now.
I just want to say, Melissa, thank you so much for being a great discussant. I really appreciate your work and your leadership in helping us to better understand our healthcare as a country, and really grateful to have the opportunity to sit and chat with you today. So thank you so much.
My pleasure.
Thank you both. First of all, please everybody join me in thanking Professors El-Sayed and Garrido. Thank you, Melissa and Abdul. I thought it was a fantastic conversation. And I want to say thank you to the audience. We had I think more than 75 questions, which is really extraordinary. Clearly, we could have gone on with this conversation for many more hours. I think it just reflects how important this topic is. I think it reflects the need that the book fills. And I think it reflects how engaged we all are at this point in history in creating the structures that generate health. So thank you to the audience. Thank you to everybody for participating. Thank you in particular to Professor Garrido and Dr. El-Sayed for a really fascinating conversation from which I learned very much. Everybody, as always, thank you for joining our public health conversations. Everybody have a good evening. Stay well. Take care.